I just wanted to ask about, like a patient visiting for, second and subsequent times.
Mm-hmm.
I think you said before that you only palpate on the first occasion. Is that right?
No. It's it. I probably what you heard me say is that that is one method to do it. You know, I do. I know some people don't. I know Kiko for the most part used to. I can't say what she does now, but 20 years ago, I actually asked her directly. I asked her the exact same question because I looked and I said, Kiko, when you see a person second time, you don't palpate. And she looked at me kind of like, like, why are you asking me this? This is ridiculous. And she went, well, better to palpate, don't you think? Basically saying, yeah, theoretically it would be very nice, but who the hell wants to bother? Kind of thing. So the story is this. You if the patient comes back the next week and says, wow, we're making great progress, everything is 80% better and it's keeping at 80% better, or it's keeping at 70% better, then you're going, I know what I'm doing. I'm on the right path here. I don't need to research it again. And then your palpation is in other words, I had the right idea. I correlated the medical history with a palpatory finding, found what appears to be the real root, because it really is affecting them in a positive way. I don't need to add anything. I don't need to change everything is good. We just need to reinforce. And then all I'm doing if I'm palpating, I'm not necessarily, well, and I might palpate, well, I do palpate, but you could palpate just kind of like wanting to be kind of out of curiosity, if you want to do that. And then you can also palpate to confirm the location of a point. In other words, okay, so when I press on liver 8 this time, is your uterus reflex getting better because you have fibroids or something like that? Something along those lines. So it's at that point, you're really just confirming. Okay. And, the longer you know that. Now, what would be true for me is that the longer I know the patient, the less I'm palpating. I tend to still palpate, for a few more visits, because you never know what's going to, first of all, because I want to know, not just from the symptoms, but also from the body, because then you're accumulating more knowledge, you're accumulating more ability to correlate things. So for example, when I started doing this style, I was much better at clearing the abdomen than clearing the symptoms. It wasn't really all that unusual for people the abdomen was cleared, but the symptoms weren't getting better necessarily, or they weren't getting it as better. And now it's kind of and then for a long time, it was kind of the opposite. The abdomen pretty much stayed, even though sometimes the severity was less, but the symptoms were getting better. So I'm just curious to see what's going on. This is assuming that everything is cool. Everything is fabulous. They're very happy, and they're just going to come for 3 or 4 more visits or whatever, and then they're done, kind of thing. They're on the right path very clearly. Okay, but if they're not, if they're coming back, and this is a subject to evaluation, obviously. Okay, so there are times when they say, oh, it didn't work at all, or it's 10% better. There are times when they say it's 50% better. And it's up to you to evaluate what does that mean for you. Granted, according to your mood and how lazy you are that day also, how much am I, because, if it's 50% better, you could excuse yourself and say, look, it's just going to take time. It's an accumulation of treatments. You can't expect for one treatment for it to be 90% gone or 100% gone and stay that way. Things that have been around for decades, it's okay if they take time. So you can give yourself that. You have to decide according to the person, the personality, and where you're at within all that, whether you want to start researching from scratch, or not necessarily from scratch, but you want to do more research, or do you want to give this time, 2 or 3 more treatments, whatever your decision is going to be. I've always been the kind of person who was a little pushier And I tend to get the patients who are pushier. I tend not to get a lot of patients who kind of come and, like, oh yeah, I'm going to see this person for the next 5 years. They're just going to come every week and lie on the table and be very happy, because they know. And our patients of that nature, they have a very busy life. They need someone to take care of them, once a week, once a month, once whatever. They just need support. That's not the majority of what I do. There are people. I remember once having a colleague in San Francisco, and she told me how she does not take new patients at all. It's not like they have to wait 3 weeks or something. They know you, and I was just like, wow. I mean, don't you get bored? Never mind. Like, how did you do this, and how is it that all these people keep coming back? But, there are different styles of practice. So because I tend to get people who, maybe it's me, maybe it's not them, but I don't believe that they're going to come back if they don't see results after a certain amount of time, or they need to see a certain amount of results, or whatever. So I tend to be more ambitious. So if they come and say, well, it's 50% better, for me, that's not satisfactory. Other people might say, well, that looks like we're on the right track. Let's just reinforce. And maybe after the 10th visit, they'll say, that reinforcement, they're still at 50%. In other words, we milked it for all it's worth. We need to find something else. We need to find another path into this person. So it's very hard to evaluate. It's a very individual thing. But if you are feeling like, okay, this is not good enough, we could do better, that's when you palpate again, you look at the medical history again, and you go, okay, I didn't leave, and what you do, you may not find new palpatory findings, and often you find less palpatory findings the second treatment than the first one. But the reason for the palpation is to find new points. In other words, you're going back to the medical history and you're going, I wonder if I can tap onto this issue. And you see how much tapping onto that issue is significant by how much does it knock down abdominal findings. Okay? So your second treatment is a chance of reevaluating and re-strategizing, and conceivably the third and fourth, and at some point, hopefully you've reached a point where you really are just reinforcing. So and at that point, you really don't need to do too much palpation. And some patients will kind of demand it. There are some patients who I have patients who if you don't put a certain needle that you put in last week, they know. They how come you don't put this on? Jesus. Now I'm under an audit. It's I'll better put every damn needle. I have a few of those. They totally, and you go, how the hell do they remember? Because it's not the ones who complain that it's painful, okay, I can understand. But the ones who, it's they somehow remember. And then there are patients who feel once they get used to palpation, and checking, it's kind of like a game. And they realize, in a sense, maybe not consciously, but they realize that they're in control of what's going on. They're an active participant. They feel cheated if you're not palpating. If you just move on a needle, they want to know. It's just like the kind of people who go and what does my pulse say? And you have to make up a story about what you think the pulse, is telling. It's well, it's saying nothing, whatever, but you make up a story because you feel like they need to feel that you're paying attention. So you take the pulse again and you think about it and you go, I wonder if I'm feeling this. And then you make up something because you need to, because it's part of the treatment. So for some people, if you don't palpate their abdomen, they will feel that something is missing. So it's all it's all about how you want to work with it. I don't think there's a real rule.
Yeah, no, I have been palpating, but what I find is, they do tend to keep some, but I keep finding new areas of, pressure pain. So then you're thinking, oh God, maybe, I have to change my change everything again, or have you got something right the last time? You know.
Well, okay, so first of all, no one says that a person has only one set of findings, and that's the findings that they're born with and die with. It keeps changing. So I mean, I hear you. So first of all, again, I would say that there are stages in practice where your relationship to these findings is different than at other times. So you might be at a phase where this is going to be a fairly prevalent phenomenon for you, that new findings pop up the second time. Now, just because new findings come, it doesn't mean that the strategy has to change. Okay? Eliminating abdominal finding is not the goal of the treatment. Okay? The goal of the treatment is to make the patient better. Your way of assessing if the patient is getting better, and your way to assess, because, for example, if they come with shoulder pain, you can do it directly against the shoulder. Is your shoulder feeling better? Yes, it is. Oh, okay, I'm successful. That's not totally true, because if I didn't address your abdomen, your shoulder is feeling better right now, but in an hour, it may come back because everything else that's making you susceptible to your shoulder pain is still there. Okay? So checking the abdominal findings is simply a way of ensuring that you're affecting the body in a positive direction. And since there's many ways to affect the findings, okay, you can clear the abdomen many different ways. With acupuncture, I'm talking about many different strategies. So you may have prioritized. It's a question of how do I prioritize, which is why I'm always looking for which points knock down the most of the findings, not just a finding, because that makes them more significant for that person. So if they come back and they have new findings, you basically, that I wouldn't take that as a failure. I would take it first and foremost as one more method of checking. It's always nice to have more to check, because it's more annoying when a patient has no findings. The first time especially. Like, you're checking the abdomen, checking the neck, nothing, and you go, okay, I have to work with theory here. That's more annoying than they're coming with more findings than you would like. And to recognize that the second time they come with more findings, yeah, my ego goes, oh, okay, I didn't do a good job. How come I didn't clear it out? How come I didn't find it last time? Well, who knows why? So I just work with what there is. So it may suggest a new strategy for me, which is great. It's not a disappointment. It's a good thing. I have a new strategy to experiment with. Or it may offer me a way to confirm my old strategy, or both. So it's actually a wonderful thing. It's not a bad thing. And by the way, it's not uncommon that there's a new finding and then it disappears. It never comes back, or it's not like it's not static enough to make a true evaluation on. It's a suggestion, just like the medical history is a suggestion, like the pulse is a suggestion. You take all these things, you combine them. It's just like in TCM. Well, where they say there's looking, there's what is it? Looking, smelling, asking, palpating. Except the palpating, they mean the pulse. And you're supposed to correlate all four of them. You're not supposed to arrive at one diagnosis, at a diagnosis from just one. Of course, in China nowadays, many schools don't even teach pulse because they say it's too controversial. It's too difficult to figure out, what is it really. And then they sort of, they've made the 10 questions and the tongue the most prevalent things, which of course, we do also. There are certain things that are more meaningful than others. If somebody has a history of diabetes, it's going to be more meaningful to me than I sprained my ankle when I was 3 years old. Unless you have some, unless I can say that sprained ankle created some weird twist in your intestines, etc., 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 it's not going to be all that meaningful. For the most part. Sometimes it is, but so you prioritize, but you keep correlating everything you possibly can. So the more you have to correlate, I would look at it as an advantage rather than going, oh, bummer. And I get the feeling of, oh, bummer, because, there is a little bit of like, oh, God, I failed. No, I didn't fail. I did not necessarily fail just because suddenly they're showing liver. In fact, maybe it was a great success because they couldn't show the liver prior. But now suddenly they're showing under the right ribs because to use the onion peeling metaphor, which everybody loves, you peeled enough of a layer somewhere that another layer, whether it's deeper or more superficial, I don't know, is willing to show itself. It may be a good thing. But I just basically I personally try not to make a judgment on it. I try to just work with it. But the thing about the second visit is it gives you something you didn't have before in terms of correlation, which is because the first visit, you're working with a theory. You're trying to confirm the theory. You've reached a conclusion. Okay, according to your medical history, your symptom and your abdominal finding, I'm arriving at this strategy, and it seems to prove itself in the sense that it's clearing the abdominal findings in the body. Fabulous. Second treatment, you're given an extra piece of information, which is, it worked partially, it didn't work. It gives you a huge amount to work with, which is why I don't charge extra for first visits. I don't charge extra for second visits, but really I should charge extra for second visit, because the real diagnosis can only happen in the second visit. The first visit, you're theorizing. You're doing your best to match it up. But the proof is in the pudding, and the pudding isn't cooked when they get off the table. How many times have you treated someone with back pain or shoulder pain or neck pain or whatever? I'm taking pain because you can see it right there and then. Or insomnia and they're sleeping on the table. But the pain people, and they get off the table and they say, oh, wow, it's great. And then, the next day they call you and tell you it's back. It happens. You're trying to minimize it by addressing their so-called constitution through the abdominal findings. So I think the second treatment is when you're getting a much better evaluation. It doesn't mean it takes that, it doesn't take longer the second visit, obviously, because you're talking with them less, you're more familiar, blah, 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 blah. But sometimes, and sometimes you'll have to backtrack the strategy and you'll say that looked like a good strategy, but it really wasn't. And I have, on occasion, reached that conclusion, started the patient literally from scratch, and then at some point later in the future, came back to strategy number one. Started working perfectly well after I've put in a different strategy altogether, having let go of strategy number one. So it's a dynamic process, and you just have to be willing to go with it. Or you do the thing where you say, I know who you are, I know exactly what you need, here are your points, here is your prescription. And then basically you're doing exactly what the TCM people are doing, except you arrived at a different prescription because your knowledge base or your database is slightly different. So instead of spleen 6 and pericardium 6, you reach something that looks kind of more esoteric, let's say, or something. You're using points that TCM doesn't recognize, that are actually useful. Fine. So you did something, but so I think the big difference in style is that you're constantly checking, that you're constantly curious about what else can be done. So I had a teacher, Dr. Jiang, she was mostly an herbalist actually, but she was a great herbalist. And she said that one of the reasons, and I really don't agree, but it's an interesting statement. She said the reason why people don't get results is because they keep changing the diagnosis. And I actually say the opposite. Keep changing, but it's okay. So, but what she was trying to say is you're not giving the patient enough time with the herbs to accumulate the effect and actually knock the thing down. And I think she has that's certainly a valid way of looking at things. But I think with acupuncture, it's a little bit different. I think that would be much more. I would take that much more seriously with an herbal approach.
Yeah.
Mm.
Yeah, great. No, I have been repalpating, as they come, but that's just getting different findings every time they come is, you're kind of wondering what's going on. But
Yeah, well, and I think that, well, lots of things could be going on. I honestly I can't say. I mean, I don't have a good dogma for it, for why it changes. But you also might want to consider, I mean, it could be something in my own skills. It could be that in the first time I was really gung-ho, I was assuming I should find something. That's the thing, that palpate is if you know nothing.
yeah,
Just palpate, then correlate. Don't immediately jump to conclusions, because if somebody gives you a medical history, you want to find certain things. So you just set that aside and you just palpate. So there's two ways of palpating, and by the way, both are valid. One is to just check everything as if you know nothing about the history. And obviously you cannot do this before you ask the history, because there's no way you can have the patient on the table, palpate blindly, and then start talking to them about the medical history. It just isn't going to work well. So you're always going to know the medical history in advance. But you can not address, you don't need to give it priority when you're palpating. But you can give it priority, and then you just recognize that you're limiting yourself. So when I don't have a lot of time or patience, I will do that. I will direct my palpation to specifically what I'm looking to confirm what I want. And then when I don't, I get frustrated, then I palpate more. But if I can find what I need, I'll just, okay, that's good enough. Another method of palpating is just palpate everything and then do the correlation after you've gotten all the palpatory findings. And that's, in my opinion, make it sound the superior way of doing it, because supposedly you found more. You have more data to work with. But look, not every patient you can do it with. There are patients who come and you're pissed off, or you just can't handle them, or whatever it is, or they're not responding well, or there's many reasons why you can do a thorough exam as you can do on someone else in other circumstances. So you just accept it and you go with it. But the other thing is, currently in today's world, with COVID and lockdowns and blah blah and blah blah, there's just so much going on for people. It's not all that surprising that they change.
mm,
I mean, remember those findings. All they are is congested connective tissue. That's all it is. It's just a reflex of some process, but it could be reflecting some other process that you're not aware of. For example, if you say below kidney 16 is adrenal, this is what you're aware of because actually somebody told you, somebody told me, somebody told the person who told me, I mean, so it's had a certain amount of history, and we have agreed that this is probably what it means. And the truth is, a lot of people with adrenal nowadays don't show below kidney 16. Okay, but let's just take that as now. Is it possible that someone can show something below kidney 16 and it is not adrenal? Of course it's possible. I just don't have a dogma for it. So I just happen to have a map with some dogmatic correlations. And then I also have to say there could be a zillion other correlations out there. And I may come to understand them at one point, or I may not, but it doesn't mean the patient can still have a connection that I don't understand. And then I do my best to resolve it. So I hope that's helpful.
yes, it was very helpful, Heavy. Yeah, thank you.
Anything else?
Did you have something, Camille?
All eyes on Camille.
Are you finished, Mary Jo? Do you have anything else?
Well, I might as well, I suppose, finish. I just had one other little thing, Avi, you probably answered in very short. It's just with the autoimmune, you did mention one time that they show redness around the neck.
Some. It's almost like they have, they're almost like red spots or almost orangey red around the neck, and slightly, it's almost like they have a tan line, but it's not. And it's not a uniform, it's not like the color, the full color of the skin. It's almost like dots, but it's fairly condensed. So it's in between. The whole skin is orangey and it's orange dots. That, I believe, that happens often with people with autoimmune disorders.
Yeah.
You know,
Yeah,
I mean,
was wondering, did it have spots, or was it just a, red coloring kind of on the skin? So
I
it's
would
kind of
say
spots.
it's like many spots. So it's not 100% orange, like, but it's all blotches.
Yeah.
But yeah, and it's sort of around REN 22, both the neck and slightly on the chest as well. When I see that, I tend to start asking about autoimmune immune disorders, or start inquiring whether towards the patient or towards myself. In other words, gee, I wonder if REN4 kidney and lung points will do a good job for this person. Yeah. Gee, I wonder if they have ping pong balls on their sacroiliac ligaments. Do they have puffiness under the occiput? Because these are other signs that tend to be there in autoimmune disorders. So I either inquire because it's amazing how people, you ask them for the medical history, they write it down and they forget things because it just never occurred to them. Or or I can inquire in myself. Well, gee, I wonder if they may have they may not have an autoimmune disorder. It may not be classified as such. It may not have a name. But when I say it's an autoimmune disorder, what I mean is the so-called autoimmune treatment, the thing that I labeled as autoimmune treatment, works for them.
Yeah.
That's why the diagnosis only comes the second treatment, because you have to prove your diagnosis. Once, if I proved it, the first treatment, I only prove it by clearing abdominal findings. Second treatment, I can prove it by the fact that it actually clears symptoms. The patient feels better.
Yeah. Great, thank you. Yeah, you can go ahead, Camille.
Insomnia, worse since the fires.
Sorry, insomnia.
It used to be, I mean, it's been a problem for years,
Mm-hmm.
but since the fires, waking up sometimes 5 or 6 times a night.
Oh, my.
No trouble falling asleep. It's always the waking up.
So is that the TCM blood deficient or the yen deficient type? No, I'm kidding. So I would say, well, there's a few things that can happen here with that kind of thing, So obviously, since the fires, I mean, so there are two big components that could come up. The quality of air is different. So just in case it's that, I mean, it's not really just in case, but I would, I would look into it. The other thing is, listen, since the fires and yes, the fires of the last 5 or 6 weeks, I believe, in California. But
right.
We've been in crazy tenseness for 6 months.
Yep.
Easily. And for some people, it's been 4 years. So it all depends on how tense one is around what's going on. So okay. I'm trying to figure out my train of thought here. So first of all, it does suggest, it suggests something in the autonomic nervous system, and it suggests specifically something in the nervous system that's unable to adjust to timing. It's nighttime. This is not the time to, go do my taxes, kind of thing. all depends on what one does when one has insomnia. But, you know, there's a certain kind of like, and I'm not sure which part of the brain exactly controls this. I guess it's the hippocampus or something. I don't really know. But there's a part of one that is supposed to sort of recognize and adjust. Okay, this is nighttime, you know. So, you know, like, you know, if you're not, say, in Spain and it's not siesta time, you know, generally you're up during the day, and generally you will be asleep during the night. So, as you know, so just looking at one's, you know, the capacity to adjust, which can be related to the stomach chi line. Okay,
Oh.
because, okay, who is the adjuster? The center is, the spleen and the stomach are. Okay? So there is a possibility that, you know, and if you were asking about yourself, if my recollection is that you do have stomach chi line. So that's a, you know, different story.
Yeah, I'm asking about myself.
Yeah, no, I didn't want to. It's okay. So, you know, stomach chi could be a big support here, you know, to be able to, now, recognizing that anything to do with the autonomic nervous system or the mind is always going to have a spleen component, one way or the other. Why? Because the spleen is responsible for the yi. The yi is the expression of the heart, literally. It's the words of the heart, okay? So if I can have a lot of mental problems, okay? And there are some people right now that we see have a lot of mental problems. I mean, in Washington. So, and they have no cognizance of the fact that they're totally unhappy, that they're crazy, okay? You may be cognizant of that, but they're not unhappy with themselves, okay? So therefore, there's nothing to treat. The only time when you can treat is if the person is cognizant. Oh, I am fearful. I am angry. I am worried. You know, I'm anxious. I am depressed. Otherwise, if the person is not cognizant of it, or I'm a selfish bastard, whichever one you want, whatever it is, you know, if I'm not aware of it, it's not a problem. You know, I mean, that would be a very Taoist way to look at it. Oh, it's just nature. You just keep going, you know. So it's when I am cognizant of it is when an emotional issue becomes an issue. Otherwise, it's not an issue. It may be an issue for other people, but it's not an issue for me. I may be an angry fuck, okay? But it's not an issue for me as long as I'm not cognizant of it. Okay. So always the spleen and, you know, and the pericardium also. So a spleen pericardium combination, like spleen 3 pericardium means always check pericardium 8, would be an insomnia option. Okay. And then you have your other autonomic nervous system options. You release the SCM with Sanjiao 8, blah, blah, blah. And then you have, well, since it's here, you can't really check the T7 line. Okay, but what you can do is you can either do moxa before you go to sleep, or put a magnet, or do both, at the center of the heel. Okay, and the explanation of that point is that you know, you can look at it a zillion ways if you like, but it's basically it's a combination of yin chao yang chao. So again, something to do with insomnia, but also something to do with how you stand up, how you ground yourself in the world. So again, coming back to this idea of, if I keep waking up, I'm not adjusting, I'm not grounding, I'm not standing up to, I'm not healing to the world as it actually is, because the world is night and day, you know, interchanging. So those would be the things, and I would check the possibility of a lung component and not just an autonomic nervous system. Just because sometimes, you know, sleep issues can be truly physical. Like, for example, the people get up every hour and a half to pee. That's a physical component. You know, it's kind of like they can't keep asleep because, you know, well, they'll be wet if they did, and they will wake up. So there's just, you know, it could be combination of different things.
So what would you do with the lung? Because I do think that this is a big part of it, that it really escalated. You know, I broke my toe earlier in the summer, and that was a little limiting for exercise. And
Mhm.
then with the fires, you know, so I do think that being under exercised
Yes, yes, that would
is
definitely, yeah, there's no
is
question.
yeah, because I mean the air quality was so bad sometimes you just didn't want to expend any extra oxygen.
Of course, of course. So yeah, and that may take time to readjust. So yeah, so there is a certain amount of I guess the word that came up to me is there's the sloth factor, quote unquote. No, that when the body gets used to sort of a certain stagnation, it's sort of like, bleh, it's hard to get it going, and then and the sleep is not going to adjust well again. So again, I would look at the stomach chi for that. Um,
And what about what in terms of, you said check the lung, but what
so
would
yeah,
you?
so well, checked. Well, if you're doing it on yourself, it's hard to know, but I would check something like lung 5 or lung 4. And even possibly lung 8, one of those three, and see what it does in your body. If there's a way for you to check, because it's all, especially when you come to the lungs, because you have one hand palpating the lung, one hand is the lung channel, and then with that hand of the lung channel, you're supposed to check your abdomen. I was like, wow, yeah, that's not going to work very well. I mean, I'm not a big proponent of doing abdominal diagnosis on oneself anyway.
Right.
I think it's very difficult to do. I know people claim they can do it, but I find it doesn't work for me personally. I just, if I'm going to do something, I just do it blindly because it's like, it's supposed to be good for you. Um, so, um, if you can reach due to a needle it upwards, that might work. If you can reach, well, you can definitely reach bladder 36. Because I think there's going to be something involving in the thighs in that description of what you're saying. Okay,
Oh,
there's not enough activity. Um, Now, by the way, the thigh and the spleen have a correlation. Well, besides the fact that the thigh is the biggest part of the flesh in a way. But well, one is a P and one is a B, but they're correlated. Okay, so I think you can look for, but my instead of looking for something on the stomach channel, like on the quads, I'm thinking UB35 because 36, sorry, 36, because it sort of gives you a jump, so it may simulate the exercise that you're missing in a sense. Even though you're exercising now, there's maybe a certain accumulation in the body of like
yeah,
downward,
yeah,
like
absolutely.
bleh. And so bladder 36 kind of like jumps it upwards. Another point that's in the thigh that's not in the quads, but inner yin has a similar option or a similar effect of, you know, um, so even though it's quote unquote on the wrong channel for the sleep option, I was thinking more on the stomach channel possibly, but maybe not. But I think so maybe inner yin and UB30, 36 might be something to also look at. You
Okay.
know, but I would definitely look at stomach chi, spleen 3, and pericardium, or some spleen points, because sometimes spleen 3 is not the best point for someone. Sometimes it's spleen 9 is better, sometimes spleen 6 and 9 is better. So, for example, if you have blood pressure issues. And if you're not sure about the lung points, just go with lung 4 gives you quote unquote more oxygen, more ability to expand the rib cage. So I would just go with that one. If you don't have a good way to test which it is and what do I think is going on, that's totally fine. No problem. And do you have diode rings, Camille?
Do I have what?
Diode rings.
Oh,
somewhere.
No, not anymore. I used to. No.
Yeah, okay. They can be extremely helpful for things like that.
Okay.
Yeah, I know they've gone out of style. So people have kind of like, but I do find that they can be very helpful, and and then because you can just wear them and sleep on the middle finger and the thumb, but it's not an option.
Yeah, yeah, yeah.
So, but I would try a magnet in the center of the heel. I would do knocks on it at some point during the day or before you go to sleep, and then put a magnet on. Now, officially, the original way to find the point is you press on the heel and you look for the spot that turns that goes white and doesn't turn as it doesn't go back to red or whatever the color is. That takes the slowest to get back to normal. That's supposed to be the best point.
Oh, interesting. I'd never heard that.
Oh, okay. Well, you did now.
Yeah,
Maybe I
no, it's
said it too
great.
fast another time. That's supposed to be
No,
the
no.
best.
It's the speed is more when you're listing points. You get really excited and you just blurt them out really fast. The
No, I
rest of
was
the time,
joking.
it's not an issue.
No, I was joking. No, because I meant 20 years ago when I said it. Um, Ideally, you find that spot that is the slowest
Okay.
to pink itself up, because that's the point that has the least amount of circulation. You're increasing the circulation there. Is the idea. But it's like, how many times do I really do it that way? I can't say. Another conceivable point to look at is possibly do 24. And when I say do 24, I mean the whole frontal hairline. So let's say from gallbladder 15 to gallbladder 15. Okay, this is a clearly Shen area. And and also in the scalp acupuncture, that area has a lot of power. So this is definitely a place where you have a lot of oomph. So that's another possibility.
Okay.
I'm not sure. Um, the press decks that Sarin has, they're so mild. You could probably try them on. Trying to go to sleep with them if you wanted to. Otherwise, they I think they still sell something. These needles are called intradermals. They're not press
Uh-huh.
stacks. And you can actually put a direct, because a press deck goes straight in, but an intradermal, you can have a direction, and then you kind of put tape over it. So what I would experiment with these points also.
Okay. Thank you. There's some good clues. And I'm not thinking very clearly, so it's helpful.
Oh, yeah. Yeah, I mean, there could be, a circulatory oxygenation issue, because,
Well, I think clearly there is. Yeah.
yeah, now you think clearly.
Well, I
No,
mean,
I'm joking.
yeah, yeah.
Um,
And I like the idea of stomach chi, because really the root problem started 4 years ago when I was buying the house in Europe, and waking up in the middle of the night for business meetings and flying 5 times in what, 8 months to set up the house, and it's never, my sleep has never been the same.
oh, okay. Yeah.
So, but it's
And
never
definitely,
been this bad. It's never been this bad. 5 or 6 times waking up in a night.
yeah. No, I hear you.
Yeah.
Yeah, then I would definitely look at that. The other thing, by the way, is I would not discount that big toe problem as not affecting your sleep. Okay, so if
Oh,
you
it
broke
wasn't the. Uh, I didn't break my big toe. I
okay.
broke the third toe.
So okay. Wait. So that's the third toe is clearly related to the autonomic nervous system, like under the third toe,
Oh, I
blood
didn't
pressure.
even think of that.
Yeah, it's part of the stomach channel, by the way, because the stomach channel goes to the second toe, but it also goes to the third toe. The third toe is not deprived of channels. It just doesn't have
Okay.
points on it. So I would, at the very least, wrap that toe with aluminum foil.
Okay, that's the light bulb that needed to go off. That's it.
Yeah.
That feels really right.
Yeah. I thought it was the big toe, which would relate to spleen and therefore to lungs as well. But and then the way you want to, and I would still try to with the third toe. If there's any still pressure pain on the third toe, you can try and go around liver 12, spleen 12 area, kneeled up towards the torso, see if that releases the pressure pain there.
Okay.
Because don't forget the liver 12, spleen 12 area is part of the autonomic nervous system. It's the point name is G-men, the hurried, the anxious pulse. G-mai, I think it's called. Sorry. The one is Changmen and one is G-mai. Okay, Changmen is spleen 12, I believe, and Chang is to rush, as G is to be anxious, to be hurried. Okay, so the gate to the rushness and the pulse of the anxious are the names of the points, and they are related to the nervous system in the exact same way that well, not in the exact same way, a little bit differently, as the Du-tu, as the tailbone is, except Du-tu has the advantage of also controlling the spine. But when the tailbone is when you're tucking, when you're pelvic, you have pelvic tilts, your autonomic nervous system gets affected. Okay, when your tailbone's pushed backwards, you're much more in sympathetic mode. You're ready to do something. When your tailbone's tucked under, you're much more in like non-movement capacity. So needling those often can be helpful for nervous system issues. And you can check that conceivably with the toe. It's a little bit easier to check than checking your abdomen.
Yeah.
So it's a little more reliable on checking on oneself.
Yeah, that's super. Thank you.
All right. Anything else before we end?
Does that insomnia point, have you do anything, like, do you use it for anything else other than insomnia?
Yes, sometimes for pain. It's supposed to be an endorphin or enkephalin releasing point, blah blah blah. I'm not someone who does well with research. But that's my understanding. That someone must have done some research on it. So they're supposed to, when someone is just like totally, it's kind of like, okay, I'm just going to try and touch this to see if we, and that they're already, so you can't evaluate anything. Sometimes just like doing these points, and if they're too hyped up, then maybe all I can do is put a magnet on or whatever, and then I can start checking other things. But there are points that I would add if there's like, someone had some major trauma and they're like in pain all over, and it's very hard to, they're very jacked up. So I would use those. But otherwise, they're literally called the insomnia points.
Yeah.
Doesn't mean they can't have other uses, but that's the main. All right. Anything else?
I'm good.
All right. Well, sleep well.
Hopefully.
I hope so. Let us know.
Thank you so much, Avi.
Thank you, and enjoy your week.
You too.
All right. Bye.
Okay,
Bye.
bye-bye.
Thank you. Bye-bye.
Bye.